So I'm going to obviously talk about obstetric emergencies, and apologies if this is a little bit self-serving in that it's a diploma topic, and so the focus is on thinking about the diploma curriculum. So apologies for the large proportion of the audience who are not doing the diploma. And direct apologies to Mal that this is another obstetrics emergency talk. Sorry, mate. So secondly, another disclaimer that it probably is not a surprise that I haven't done an obstetrics fellowship and I haven't done midwifery. So I am not necessarily an expert in this topic. I've tried to, where I can, sort of bring this into a retrieval context, and the majority of the retrieval around obstetrics is probably not done by us, and it's more done by the air ambulance service with the flight nurses. So this doesn't necessarily fit into our day-to-day work, although sometimes it might, and I'm sure we've all had a few obstetrics cases in the job. So in New South Wales, we have tiered perinatal networks, and so they're similar to kind of a trauma network where it's a geographically associated group of hospitals. And there's 8 networks in New South Wales, and each of them is kind of linked to a level 6 obstetrics unit, and as well as a level 6 or level 5 neonatal intensive care. Within these, there's a senior obstetrics consultant. So that's a local obstetrics consultant to that network. And so that'll be the obstetrics consultant who's on call for the receiving hospital. And then sort of adjacent to that is a state obstetrics consultant who is available kind of for secondary advice, secondary advice, and also just decisions around complex cases where retrieval is involved. And then all of this is accessed through the ACC for making retrievals. This is taken from the tiered perinatal network guidelines for New South Wales, and it's just a matrix for decision making around retrievals of pregnant women. So you can sort of see on the right hand side of the screen is very low acuity cases where they can be moved by a patient transport provider, and then right up to the left side of the screen, which are sort of immediate cases, and this is things where there's preterm labour with imminent birth, and they are sort of immediately dispatched, and that might be midwife plus minus a medical escort. Down the bottom, there's a couple of things that sort of say, for example, multiple pregnancies, where if the patient is carrying multiple fetuses, then that would just push them up a category in all cases. So for the talk, I'm going to just sort of break it down into antepartum emergencies, emergencies during delivery, and postpartum. And the bulk of the talk, and particularly when you're looking at the diploma curriculum, is in the antepartum emergencies. And so this is where we have things like antepartum hemorrhage, premature rupture of membranes, preterm labour, pre-eclampsia. And they're the things I'm going to talk about today. And then it's also just a reminder to think of the other things that go along with pregnancy that might cause emergencies, such as cardiomyopathy and heart failure and PE, both of which make up a huge part of the non-obstetric mortality in pregnant patients. But I'm not going to talk about those ones today. So kicking off with antepartum hemorrhage. So these are the 3 sort of main causes of antepartum hemorrhage, or the 3 serious causes. And just keep in mind that a large proportion of antepartum hemorrhages often don't have a diagnosis, or it's not known why there's PV bleeding. So first of all, with placental abruption, and this is probably the most important antepartum hemorrhage for us because it's the most life-threatening cause. And in addition to that, it's associated with trauma, so we're more likely to be involved there as well. So what it is an early separation of the placenta before it's meant to. So anytime up until the end of the 2nd stage of labour, if there's a separation of the placenta, that's placental abruption. And like I said, it's associated with trauma where there's a blow to the abdomen. It's also associated with cocaine, methamphetamine use, multiple pregnancies, pre-eclampsia, and polyhydramnios as well. So the presentation of this, there's often PV bleeding, but there may not be. There's a sort of quite intense pain associated with this, and this is the painful contractions of the uterus, and then that can be felt on examination as the uterus feels tense and woody. The bleeding, as I mentioned, may be present, but it may also be concealed depending on the lie of the placenta in the uterus. So that picture on the right is a concealed abruption. And it may only be a small amount of vaginal bleeding associated with that, which really hides the true amount of bleeding that can occur. And so these women can become hypovolemic and quite unwell, and they can develop DIC from this bleeding as well. And then the other thing that occurs is that it can sort of precipitate the onset of labour, and labour can occur rapidly because that uterus is very hypertonic. So the other tricky important thing to note about this is that the diagnosis can be a bit difficult. So you often think of doing an ultrasound to look for bleeding, but that blood, especially in a concealed hemorrhage, is the same echogenicity as the placenta. So an ultrasound is not very sensitive in picking this up. And the gold standard is using doing a CTG for 4 hours to look for signs of fetal distress because they're not getting adequate blood supply. Moving on, the next cause of placenta previa, and that's where you've either got a complete or a partial covering of the internal walls of the cervix by the placenta. And this situation is usually known about if the patient has been having their sort of ultrasounds and antenatal care. And if that's the case, they're usually booked in for an elective cesarean around the 37-week mark. But potentially this could be a surprise if the woman hasn't had antenatal care. And this, compared to placental abruption, usually presents as painless vaginal bleeding, usually in the second, but more likely the third trimester, and it sort of comes on a little bit more slowly and insidiously. These patients still may become hypovolemic and they may need resuscitation from the bleeding. And then finally, vasoprevia is slightly different. So this is caused by a filamentous cord insertion, and that means the cord, rather than coming out sort of directly from the placenta, flows between the membranes, or travels between the membranes of the chorion and the amnion, and where it goes over the cervix, that cord is at risk for being damaged and bleeding. So this presents as painless bleeding again, and it's usually very bright red bleeding. And the reason for that is because this is actually hemorrhage from the baby's circulation rather than the maternal circulation. And so even a small amount of bleeding can be very detrimental to the baby, and an urgent cesarean would be needed to save the baby's life. Fortunately, however, this is quite a rare thing. So the next thing to talk about is premature rupture of membranes. And for me, this is just getting my head around the terms and what they mean more than anything. So the other term for this is pre-labor rupture of membranes, which it makes it a little bit easier to understand. And so, essentially you've had rupture of membranes before the onset of labor, and that's what PROM is. With rupture of membranes, there should be a clear fluid, but sometimes it's a bit hard to tell, which makes these cases a bit more difficult. We've got term PROM and we've got preterm PROM, and term is anytime after 37 weeks. And these patients can be either managed actively in sort of expediting delivery or expectantly as well. They don't necessarily need routine antibiotics unless there's a risk factor for infection, or if the mother's showing signs of infection like fever. There's meconium in the fluid, or depending on the fetal presentation as well, they might give antibiotics. That's in contrast to preterm pre-labor rupture of membrane, so that's before 37 weeks, and these are much higher risk for infection, but also a few other complications like having cord prolapse, because there's more space for that cord to fall through, and antepartum hemorrhage as well. So in these cases, they are admitted into hospital generally, and they're monitored and given prophylactic antibiotics in all cases. If they're less than 35 weeks, they're given steroids, and this is a treatment that will come up in a lot of the emergence throughout here. And for especially those sitting an exam, it's a number that you probably just need to know, a prescription you need to know. So it's betamethasone. It's 11.4 milligrams every 12 hours for 2 days. So with the next topic being preterm labour, there's sort of two conditions here where you have preterm labour, which is regular contractions anywhere between 20 weeks and 36 weeks plus 6 days, so before 37 weeks, and that's with cervical dilation. The other term that confuses is threatened preterm labour, and so the difference there is that they still have painful contractions between 20 and up to 37 weeks, but there's no cervical dilation. The aim here is to transfer the mum and baby together, so the fetus in utero, to an obstetric centre, and particularly the younger or the earlier the gestation, the higher risk is accepted. So in the perinatal network guidelines, the sort of term they use there is that you accept a high risk for birth en route, particularly for babies less than 28 weeks gestation. And I guess that's weighing up the benefit of having a preterm baby born in an obstetrics centre with neonatal support, as opposed, weighing that risk up with having a delivery en route. The only sort of exception to this is if the transport would put the mother's life at risk, in which case, obviously, it's better to manage that on site, and then obviously would need a NETS retrieval for a newborn delivery there. With these preterm, there's the question of whether you're getting tocolysis, and the answer to that is basically if there's a benefit in delaying birth. And so that benefit would be for more preterm babies, so that could be to get them to a tertiary centre. It's also to give steroids a chance to work, and so that's delaying the birth by about 48 hours to allow the steroids to work and have that fetal lung maturation as well. And so the first line management here is nifedipine, and it's 20 milligrams orally for every 30 minutes until contractions subside, and then it's every 6 hours after that. So that's a medication that might be seen there. Other things to think about aside from steroids, which we mentioned earlier, if they're less than 35 weeks gestation. Other things are magnesium sulfate, and this is given for neuroprotection. It's been shown in premature babies to prevent cerebral palsy, and particularly the motor deficits that come with cerebral palsy. That is given for less than 30 weeks gestation, definitely, and up to 34 weeks gestation, they'll consider that giving magnesium. It's the same dose as for pre-eclampsia, which we'll get onto shortly. And then the last consideration is that they need antibiotics. And if they're in established labour, preterm labour, they're often given antibiotics prophylactically for GBS, regardless of if the status is known or not, just to make that decision making a bit easier. And then that's ampicillin for GBS prophylaxis. And definitely if there's chorioamnionitis, meconium, Sten-like, all that sort of thing, then the mother will get antibiotics. All right, so moving on to pre-eclampsia. So pre-eclampsia is on that sort of spectrum of hypertension in pregnancy where You've got hypertension without consequences all the way through to severe and fatal consequences. It is defined as hypertension, either systolic greater than 140 or diastolic greater than 90, that begins after 20 weeks gestation and involves another organ system. And so that's things like, so the neurological symptoms, that's headache, visual impairment, hyperreflexia, and if there's seizures, that's eclampsia. Renal, that's proteinuria, oliguria, or creatinine greater than 90. Heme, that's things like thrombocytopenia. Hepatic is both the change in transaminases, so elevated transaminases or right upper quadrant pain. Pulmonary edema is self-explanatory, and fetal growth restriction as well. And it's quite an important cause, so I was surprised in developed countries, this is the cause of up to 16% of maternal deaths. So fairly important, and I guess it's fairly common as well. We see it quite regularly. And the cause of preeclampsia is its abnormal development of the spiral arteries in the placenta. And so the management, being a blood pressure problem, we're going to use antihypertensives. And in the sort of mild spectrum of disease, these will be oral medications. That's things like methyl-dopa, labetalol, nifedipine. But the more severe things, which we're probably more likely to be involved in, is using IV medications to get rapid control of that blood pressure. So that's labetalol and hydralazine as well. Interestingly, a systolic above 140 is the definition of preeclampsia. But when you've got severe hypertension, you're not trying to bring the systolic blood pressure down below that. You're still trying to aim for around 140 to 150 to maintain perfusion to the fetus through the placenta. The purpose of bringing down the blood pressure is to prevent some of the other complications, so like intracerebral hemorrhage and then progressing to eclampsia as well. If it's less than 35 weeks gestation, corticosteroids, as the same as the other conditions we've mentioned, and magnesium sulfate, not necessarily for the fetal neuroprotection, but this is for seizure prevention and blood pressure management as well. So magnesium sulfate's definitely indicated in severe hypertension, and maybe usually are used in sort of more moderate levels of hypertension as well. It's definitely indicated where there's signs of imminent eclampsia as well. So that's things like severe persistent headache, hyperreflexia as well, and the visual changes. And then the last thing in the management is delivery. And so the aim would be to stabilise the woman as much as possible before delivery, without delaying delivery too much. Depending on how severe and stable that patient is, there may be a delay into a delivery to give steroids some time to work if the blood pressure is under control. But if the blood pressure is not controlled or it's eclampsia, they're probably going to want to deliver the baby very quickly. And so delivery is the case sort of throughout sort of the gestational period. And there's been articles about whether or not to do expedite delivery or manage expectantly. And it was interesting to note that if you manage expectantly, a third of the women will have complications in the next 2 weeks. So that's sort of severe things like renal impairments, seizures, intracerebral hemorrhage. And so most of these patients are delivered very quickly. And finally going with this is eclampsia, and this is where I do have a story where this has had a job last year, and it was which has a few lessons in it, so I'll tell the story. There was a lady in her late 30s who came in after a seizure into Griffith Hospital, and she didn't so she got intubated purely to facilitate having a CT. And so we passed on with mission, and we retrieved back in and a little bit of why I couldn't handle a patient in Griffith. And the reason was that she was 200 kilos and we were a bit worried about getting her there. And the only other bit of information was that she had a very low level of HCG. It was around, around 5,000 or less than that even. And so she had been dismissed by the local obstetrics pregnancy that this is early pregnancy or she had a miscarriage. And so they sort of washed their hands of her. And so we went to go and get her, and it wasn't until we were en route at Griffith Airport that the night doctor had come on that evening and did an ultrasound. And this lady had a 26-week pregnancy. So this obviously was eclampsia. And so my lessons there were beware the surprise pregnancy. And even in this woman, she was obviously very overweight at 200 kilos. And even knowing that she was pregnant, I couldn't feel a uterus. And then the other lesson is also beware the low beta HCG can also go with a late stage pregnancy. And so she was retrieved and had an urgent cesarean in RPA. And apparently the baby did okay, considering it was 26 weeks. So the management of eclampsia is treating the seizure, and it's acceptable to sort of treat that with benzos like midazolam, which we carry in our thigh pouch, so that's quick to get to. But the real treatment of that, the definitive treatment for the seizure is using magnesium sulfate. And so the dose of this is something that would be important to know. It's 4 grams over 15 minutes. And then doing a 1 gram per hour infusion. And it may be, if we're retrieving these patients, that they're already onto their infusion for a number of hours now. And so it's important for us to monitor for signs of magnesium toxicity. So that's looking at their reflexes for hyporeflexia and respiratory rate and blood pressure, and may need to adjust based on those things. The second part of managing eclampsia is controlling the hypertension, which we've already sort of touched on with medications like labetalol and hydralazine. And then finally is delivering the baby, and as soon as that mother is stable to go through a cesarean, and it's feasible. And finally for antenatal complications, just to sort of touch on fetal death in utero, often sort of detected or presumed when there's decreased fetal movements after 28 weeks, but it needs to be diagnosed on an ultrasound to make that diagnosis. And I put this in because these patients often move to places with obstetrics units, and obviously they need to go for the ultrasound, to have a high quality formal ultrasound, but then to have discussions there with the staff on how the baby's delivered and when it's going to be delivered. Then they also have sort of the social supports and counselling to go around with that, and parents can spend time with the baby and things like that. They also have access to all the follow-up investigations and examination of the baby that often happens after a stillbirth. So just a couple of complications that occur during delivery. And the first one what I talk about is the unexpected delivery. So I guess for to dealing with really little people all the time, it's good to know that this is kind of, most babies are delivered uneventfully and don't need support. So 90% of babies will be fine without any support. 10% will need just something simple like drying and stimulating. Less than 5% need ventilation, and less than 1% need compressions and intubation. So hopefully the numbers are on your side when you come across an unexpected delivery. If you've got time, do an ultrasound. This will help with the presentation of the baby and the lie of the baby. Take an antenatal history. It would be obviously very pertinent to know their gestational age and if they have any risk factors. if they know there's 2 babies, for example. Another place where an ultrasound might help you. And then preparing the area, having an area for resuscitation with a warm, well-lit area and all the equipment that we need for neonatal resuscitation, which I won't be going into in this talk. And then the last thing that's probably important to know is about delayed cord clamping. And so that can be done and sort of encouraged to be done if the baby's well and they're crying and breathing. And so the baby can go up to mum's chest, and after a minute or so, clamping the cord and cutting the cord. Obviously, if the baby's unwell, if they're not breathing, then we want to expedite that, do that immediately, and move the baby over to the resuscitation area. I'll just touch really quickly on shoulder dystocia. This probably don't have time to go through all the particular components of it. But this is when the baby's head is delivered and the anterior shoulder impacts up against the mother's pubic bone. And if that head is delivered and the baby isn't delivered within 1 minute, that's when you need to be kind of jumping into shoulder dystocia mode. The other thing that they talk about is the turtle sign, where the fetal head is delivered and then retracts after that initial contraction. So, like I said, I won't go through all of this, but the sort of main initial parts of this mnemonic are calling for help, but then doing the McRoberts maneuver, which is that sort of legs up to chest, and then applying external pressure over the suprapubic bone. So just above the suprapubic bone and not on it. So you're helping that shoulder to go under the bone. And then there's the rotations and trying to slip their arm out and going on hands and knees as well. And then finally evaluating for surgical procedures like episiotomy and cesarean section. The other one to be aware of is breech delivery. And again, I won't go into a whole lot of detail about it, but so breech delivery is where the presenting part is the buttocks, and a footling breech is where the presenting part is the legs. And once those parts are sort of delivered, it's important to hold the baby by the pelvis and not by the abdomen, because you can do a fair bit of damage. The arms are delivered then through what's called the love set maneuvers, and that's sort of folding up their arms up into their chest to try and extend their elbow down and deliver their arms. And then the other important thing to know is about delivering the head. You need to be very careful with that. And so this is a picture of the MSV maneuver. I'm not going to pronounce the French names, but that's sort of placing your 2 fingers on the baby's maxilla and then 2 fingers on their occiput as well, just to control the head as you're delivering the baby. And finally, in complications that occur in delivery, just to touch on amniotic fluid embolism, which is fortunately quite rare. But these patients do become very sick very quickly and through a very sort of complex pathophysiology. So this occurs when amniotic fluid is released into the maternal circulation, and that's either through a tear in placental membranes or a rupture of a uterine vein. And amniotic fluid contains lots of procoagulant proteins and inflammatory and vasoactive proteins as well, and that explains a lot of the causes. So if we think about that, having an embolism going up to the pulmonary circulation is going to cause hypoxia and hypotension. Having something procoagulant is going to cause coagulopathy, and this can be quite severe, and they get DIC often. But then it's also described like an anaphylactoid reaction where because of all those sort of vasoactive proteins, they get things that look like anaphylaxis. So that might be flushing and agitation, a cough as well, and the dyspnea that goes along with that. And they might even get bronchospasm, and it has been treated with adrenaline for that. But the general management of amniotic fluid embolism is supportive through this. You're going to look for coagulopathy and correct that with blood products, using vasopressors and inotropic support, and they ought to be a candidate for ECMO. And then finally, in postpartum complications, I'm just going to talk about postpartum hemorrhage fairly briefly. So this is categorized as minor, severe, and massive. So minor is 500 mils to 1,000 mils of blood loss, which doesn't sound very minor to me, but apparently that's a minor classification. Severe is greater than 1,000 mils of blood loss or signs of shock, and a massive PPH is greater than 2 litres of blood loss, or they're shocked, or you have a massive transfusion protocol, and that's the definition of that. It can also be defined as either primary PPH, which is within the first 24 hours of delivery, or a secondary PPH, which is after 24 hours, up to 6 weeks. And these tend to have different causes, or not different causes, but the causes represented. If you are in the situation of a PPH, the basic manoeuvres would be giving active management of the 3rd stage of labour, so syntocinon, 10 units IM, then going on to give an infusion of that, so that'd be 40 units in a litre given over 4 hours. Fundal massage, so the midwives are obviously very good at this, and that's just rubbing up the fundus to try and tension it up, and that sort of goes through a bit of a progression which ends in that sort of bimanual compression. Draining the bladder as well, so placing an IDC, that will inhibit the uterus to create tone, and then going through your causes, and so that's the 4 T's. So the most common, particularly in a primary PPH, is going to be the tone of the uterus, and so you might expect that in somebody who's been labouring for a long time, or multiple pregnancies. Then the other causes are trauma, so you want to be inspecting the birth canal and repairing trauma with pressure and sutures where applicable. The third T is tissue, so that's retained products, and this will be more represented in particularly secondary PPHs after 24 hours. And also being thrombin, last T being thrombin, so that's just a coagulopathy or DIC, which you need to look for and correct. And the management, in sort of short, is resuscitation. Interestingly enough, the guidelines for PPH for New South Wales, it seems a bit crazy for what we're dealing with, but the guidelines say that sort of start to think about and consider blood products when they've lost 1.5 litres of blood, or they're showing signs of shock, or consider blood products when you've used 3.5 litres of saline of crystalloid, which just sounds insane, and I hope that's not actually happening. TXA, obviously we're going to give, and then surgical management if there's ongoing bleeding. And so this is a picture of a Bakri balloon, which is a balloon that's placed inside the uterus and inflates up to 500 mils, depending on the size of the uterus, and that's instilled with sterile water, not air or anything like that. And that can be left in for 24 hours. So I guess it's conceivable that these patients might be transported with a Bakri balloon, but I sort of spoke to one of the flight nurses, and they said that if they've got one of these in, they're probably staying where they are because they're at a place with obstetric expertise. And then finally, in surgical management would be something like a hysterectomy, and that's obviously a very big decision to make, and that's considered on a case-by-case basis. But that's more likely in women who have placenta accreta, so invasion of the placenta into the uterus, or a uterine rupture, or even uterine inversion. But obviously that's a big decision to make on a case-by-case basis, and it's usually to obstetric consultants who make that decision. All right, so that is the end of my talk, and so it's a bit of a rush through whirlwind tour of all the topics there. I hope that sort of jogged memories and helped you remember some of those things that we don't see very often.